Next up is mental health and intellectual and developmental disabilities, a community provider training program for Washington State presented by Rachel Earl and Jim Mancini. If we can have you all come up, thank you. Now, Dr. Rachel Earl is a clinical psychologist and faculty member at the University of Washington, specializing in the assessment and treatment of intellectual and developmental disabilities, including autism. She previously served as director of the Mood and Anxiety Program at Seattle Children's Autism Center and currently practices at Child and Adolescent Psychological Services of Seattle. Dr. Earl is passionate about adapting evidence-based therapies to meet the unique needs of neurodivergent youth and is committed to delivering neurodiversity-affirming care to children, teens, and their families. Jim Mancini is a licensed speech-language pathologist with nearly 25 years of experience supporting individuals with communication challenges, particularly those living with autism, intellectual and developmental disabilities, IDD, and co-occurring mental health conditions. Currently, Jim serves as a director of the Washington Include Collaborative at the University of Washington, where he leads efforts to train professionals statewide in neurodiversity, IDD, and the intersection of mental health and disability. Through Include, he promotes community development, strengthens provider networks, and advocates for equitable access to care. Jim is also involved in statewide training initiatives, including the Washington State Autism Center of Excellence and the UW Mental Health Institute's IDD track. Welcome.
Thank you, everybody. Yes, I am a speech-language pathologist. Any other SLPs here? Yes, we got one. That's good. We need more of us in mental health, and I know that OT was one that started getting support through in behavioral health agencies. We need SLPs in there too. So, thank you, Chad's Legacy. Thank you, Laura and Todd, for offering us this opportunity. And what I love about this so far already is just this call to action that is already so palpable. And following Todd's this morning, I'm going to say up here in person that I'm on some fluoxetine and I'm on a little bit of clonazepam when needed. So, and I should have probably taken it this morning, but I didn't. So you guys are going to just have to let me to do this. So we're here to talk about the intersection of intellectual developmental disabilities and mental health, which is surprisingly fairly new. And I'm going to ask another audience participation here. Anyone heard the term diagnostic overshadowing? Just put your hand up if you've heard of the term diagnostic overshadowing. Wow, I am surprised. Thank you, Carice, for raising your hand. Diagnostic overshadowing. I'm gonna read you the definition. I just found it on the internet. Diagnostic overshadowing is a bias where clinicians misattribute a patient's symptoms to a known existing condition instead of exploring a potential new or comorbid condition, okay? So when we think about this in the population we're talking about, we're thinking about people with IDD or autism who might have some complex behavioral issues, and all of their behavior, all of their challenges are attributed to their disability, whether it's autism or IDD or something else, TBI, and not this co-occurring mental health condition. In the advent of neurodiversity over the last couple of years, we know that there is an intersection of mental health and neurodiversity and IDD. So we have not done a good job with this across the world, across the country, and certainly in Washington State. It wasn't that long ago when behavioral health agencies simply denied care because the word autism was on the child's records or the individual's records. So we've got a lot to do, right? And if you think about, all of the different mental health conditions that are out there, anxiety, depression, trauma, especially trauma, when we think about some of this population. You think about some of the kids who are getting restrained, they are getting secluded. That is a traumatic experience for those individuals and their parents, for that matter. So we have a call to action here that we need to do. So So as a result of diagnostic overshadowing, these are things that we see, that we've observed in Washington State. We have a high utilization of services, and these services are often very siloed. Mental health providers don't communicate with the neurodevelopmental providers, right? Medical and mental health and school are very, very siloed, right? We have these high occurring rates of behavioral and mental health challenges and these people are ending up in the emergency room, in psychiatric care, in prisons. And Dr. Gary Stovey, who I think is online today, is leading up a project called the ANEW Project, which is really looking at our prison systems and saying, how many of our people are stuck in the prison because they have an IDD and a mental health condition, and they have nowhere to go, right? That is really one of the big problems. We have long wait lists, limited access to providers, and we're going to talk about what we did because of that, that qualified providers, I should say. The inadequate supports can exacerbate crisis. Not only exacerbate, they can worsen, they can actually cause trauma in these situations. So we need to avoid that. Responsibility and blame is being tossed around across systems. No, it's DDA's work. No, it's the healthcare authority's work. No, it's the school, right? When in reality, this is for all of us. This is our community that we need to be supporting. So thank you. So, my friend Katrina Davis, lifelong parent advocate, she calls it a game of hot potato, right? Because nobody wants to take ownership and responsibility over these kids, or these people. So, which results in this reduced quality of life. So I'm going to talk quickly about our Include Collaborative, and I'm going to pass it over to Rachel Earl. We are called Include. That stands for the Interdisciplinary Network of Community Leaders with a focus on the underserved and disability education. Those first four letters, interdisciplinary network of community leaders. I hope that includes everybody here, right? This is what we need in our state, is everybody taking a role and taking a part in the support for these people. And then the second part, focusing on the underserved and disability education. You cannot do this work if you are not thinking about diversity, equity, and inclusion all the time for every single patient. Thank you. So quickly, we focus on education and training, right? And that includes the pipeline, that includes undergraduates and those in school. We are housed at the Institute on Human Development and Disability. We're closely associated with our LEND program, which we're a little worried about not being funded, thanks to some people in our country. So we need to be thinking and working together. Our goal is to build a statewide network, and I'm going to show you a map in a minute that illustrates that. We are very focused on community outreach, especially to those underserved communities, and we are at the University of Washington. We have an obligation to inform our policymakers, and thankfully we're at the UW, and we are able to collect data, measure what we're doing, is it effective, and then share that with our partners at the Healthcare Authority, with our partners across the state, and we've been really, really lucky, I think, so far in terms of getting that type of work done. I'm going to go through these quickly. This is an overview of our Washington Include initiatives. And then here is our state, and if you notice, we have somebody in one of our ECHO programs, which I'll talk about in a second, in every county except for Ferry and Lincoln. So if you're in Ferry and Lincoln, please call me. Right? Send me an email. We want every county to be represented. And then I'm going to finish up here with a quick example of why we got to where we are and why we put together this program. So coming back to our partners at the Healthcare Authority, we got funding a couple of years during the midst of COVID to begin an ECHO program. If you're not familiar with what ECHO is, please look it up. It's a really wonderful mentoring program that was developed out of the University of New Mexico. The ECHO IDD program, there were some visionaries at the Healthcare Authority. Gail Krieger, I have to call out Gail. She should have a building named after her. Absolutely, so, and a good one, right, a nice one. And then we've also got Paul Davis here, and Paul is our number one man, and Paul should really have a boat or an orca or something like that named after him. But it was that vision and that ability to support, hey, we need to get in front of this issue that is this crisis, and it was prophetic, because we are in crisis in this community, right? So, and after running this ECHO program, we have ECHO programs that run twice a week across a lot of different topics. And we learn that it's an opportunity for everyone to learn, including those of us. We show up with a lot of humility to be able to say, we don't understand everything, so why would we expect you guys to understand anything? Let's all learn together. What we learned was that in our ECHO IDD program, which was designed for WISE teams specifically, our first go-around, and then broadened out to other behavioral health agencies, ABA, and neurodevelopmental supports, and the medical community, that, man, our community of providers do not have the training. They do not know how to work with someone with a communication deficit or delay. They do not know how to work with someone who needs occupational therapy due to their sensory issues. So we developed this program that Rachel's going to describe as a result of what we learned from our ECHO program. So I'm going to give it away to Rachel.
All right, so we want to talk to you today about mental health and intellectual and developmental disabilities training program that was developed and implemented last year that is really a proposed solution to all of the cyclical challenges that Jim is noting and the siloed levels of care. And this particular training, which I will go ahead and describe as MHIDD from here on out to try to make that quicker, is a virtual training program, and it has 3 specific aims. The first aim is to increase awareness about the intersection of IDD and mental health. And when we're talking about intellectual and developmental disabilities, we're talking about autism, we're also talking about ADHD, intellectual disability, fetal alcohol spectrum disorders, learning disabilities, a variety of developmental diagnoses that are all going to impact your experience and co-occurring mental health challenges. And by increasing awareness, that actually has a 2-fold aim, because if providers are not confident in understanding developmental disabilities and are turning away individuals, then they are not receiving early intervention and preventative care. In the same breath, if patients are coming for a mental health concern but have an undiagnosed developmental disability and clinicians are not aware of symptoms and presentation of neurodiversity, then treatment is not going to be as effective and individuals might go further undiagnosed. So diagnostic overshadowing works both ways, and this type of training is targeted specifically to community mental health providers so that the people that are on the front lines can be providing preventative care. Our second aim is to increase skills and knowledge that providers can immediately use with their clients and share with their colleagues to better serve this population. In talking with individuals who are neurodivergent, who have an IDD, there are many experiences of failed therapy, of being told that therapy didn't work, or that counselors were not able to support them and they get turned away. And it is our goal that individuals will have a positive and neurodiversity affirming experience in their mental health care. We want to equip providers with confidence that they can do this work and also make sure that clients are getting care that is neurodiversity affirming. Our third goal is to foster community with like-minded professionals. We know that community mental health is a challenging profession to be in, and burnout, as we all know, is very, very common. And so we want to pull and leverage community and individuals that want to do this work, that want to serve complex patients with IDD, and provide a lasting support network so they can keep doing this work. This is a fully virtual training program and was designed to be modularized so that we could be better able to suit the specific needs of a given provider setting. As I mentioned before, it's education about mental health and IDD, but also providing both broader clinical skills that we think about when we think about neurodiversity. How are we meeting sensory needs? How are we thinking about goal setting? How are we leveraging caregivers in the conversation, partners, friends, individuals that are part of their community, and how are we thinking creatively about how we can identify ways of communicating mental health symptoms and presentation? We want to connect providers with resources that they can use practically, but furthermore, we want to connect them with community consultation opportunities. And this is where UW Include came into as that partnership. That ability to say, okay, if you're here and you want to do this work, let's get you into a community of providers that is doing this work on a regular basis to support each other and provide direct consultation about complex patients that you may be seeing. So our current structure for MHIDD is twofold. The first is an introduction series, and this is identified as a 1 or 2 day workshop that provides introductory information. It gives information about how to be neurodiversity affirming in your care. It gives some context for the neurodiversity affirming movement, how we're thinking about this siloed levels of care and how we start being more interdisciplinary. And it's intended for both direct care providers as well as those in the broader system. It's intended to be an introduction and then to bring people in for more support. So we then identified a clinical skill building series and built out an 8-week course for individuals who are direct care providers. These are folks that are working directly with patients and are looking for additional clinical training in how to adapt evidence-based practices more effectively, how to consider what assessment and treatment of IDD looks like. Okay, excellent. In addition, as part of both this introductory series and the clinical skill building series, we were really fortunate to have an interdisciplinary team, and this was vital to the success of this program. It's a dedicated team of experts to support the learning of providers through both didactics as well as case presentations, so people can see how is this being played out in cases that are relevant. Our dedicated team was interdisciplinary for a reason. We want to break down these silos of care. Our dedicated team at each point involved a self-advocate. We want to elevate lived experiences, and that is essential as we think about doing this work. A clinical psychologist, master's level mental health counselors, a speech language pathologist, as well as guest presenters in a variety of disciplines who would come into guest didactic presentations. I'm going to be reviewing the topics we covered in just a moment. The piece I really want to make as clear here is that this is a particular type of training where we are at each point elevating lived experience. There is a long history of individuals with IDD being told what their experience is from providers that don't fully understand that experience. And so we had, as part of our training, rotating lived experience presenters that include self-advocates, family members, caregivers, those who have navigated these broken systems and have really important insights for how we're going to move forward. This is a variety of training topics that were covered in our clinical skill building series. And the thing I want to highlight here is that we covered a variety of different topics to try to give an introductory sense of, at each point of these various mental health co-occurring conditions, how can you get some tangible and practical supports for your practice. We started with ethical considerations, and first and foremost, how do we respect people's autonomy? How do you respect autonomy of an individual who is non-speaking and is presenting with symptoms of anxiety and depression? What does that look like? Our session 2 focused on assessment. Now, this is something that community mental health providers may not be doing this direct assessment themselves, but we want providers to be aware of what the possible presentation might look like that might require them to refer out for further evaluation. What are some questionnaires that they can be using to inform their practice with this individual? We also want to leverage relationships, community, family therapy. How are we thinking about the system that a patient is in, and how are we pulling those folks into treatment? We cover anxiety assessment and treatment, depression treatment, and suicide risk assessment. We know that individuals with IDD are at a much higher risk of suicidal ideation and attempts. It's an area we need to do better, and we focus on what does risk assessment look like for individuals that may have limited communication or non-speaking. We also talk about partnering with speech and occupational therapists. Clearly, this is something that is so very, very important. And again, as part of breaking down those silos, we want to make sure that a community mental health provider feels equipped to reach out and network and team up with an individual's speech or occupational therapist, as well as helping their patient potentially seek out those resources if they don't have them already. This is where we focus on really understanding sensory needs, understanding adaptive skills, and then understanding communication, alternative communication opportunities. How are we supporting our client holistically beyond, if we're only looking at mental health and those symptoms in particular, and we're not considering communication, autonomy, independence, sensory needs, then we're missing what is important contributors to how someone feels able to meet their goals and to live life the way they want to. We then talk about severe behavior dysregulation, knowing that a lot of individuals with IDD who do not receive care early end up seeking crisis care and display signs of dysregulation that for many community mental health providers it feels like something they can't address. And so we really want to better equip community mental health providers with confidence around these issues. And then we talk about medical complexity. How do we understand partnering with medical providers, with psychiatrists, with thinking about medication management so that, again, community mental health providers can better support their client holistically. In 2024, we were fortunate to reach 524 individuals register for our intro series and 192 for our clinical skills series. This was a huge turnout, far more than we expected, and really speaks to this is information and training that people want. We also were able to serve individuals, providers, and the folks within the system from a variety of different settings, notably 50% coming from community mental health, and then the remainder coming from really frontline individuals that are supporting in higher intensive care centers, in supportive living, as well as in preventative settings like schools. We also received great program feedback from those that completed our survey. Strong agreement that this increased their confidence, it added pertinent skills to their toolbox, it provided a safe place to share and learn, and it increased their expertise and their confidence that they can support this population. Our primary goal is to foster connection and community and to support complex clients with IDD. Our team is looking for a way to continue this work, and it has been shown, we have a program, it has been implemented, it has been shown to work. We want to reach more providers. We're ready for immediate implementation. We just need you to think how we can expand our reach and how we can continue to provide this support. So I know we are almost out of time. I am going to turn it over to Jim for one more minute.
Thank you, Rachel. And this is just going to start feeling repetitive, so I think we should go to questions as quickly as possible. If you are interested and want to include, please reach out. We got Sini Rose over here. Put your hand up, Sini. So go talk to Sini. Sini has a lot more schmoozing ability than I do, so she is the one to talk to. We got Carice over here. Sophie Lou's over there as well. Please join us. You're all welcome to come see one of our echoes. Come join our community and let's figure this out together. So, questions?
I noticed on your list of training topics that you didn't include psychosis. And something like 35% of those presenting with autism might experience psychosis. Was it just not on your list, or how does that figure into your program?
It's a great question, and we have been working with the Spirit Lab. Gary and I presented at the psychosis conference last week, and it is certainly something that we need to be thinking about. One of our echoes is called Echo IDD Psychiatric Care, and we have talked about and brought experts in psychosis into that space, and you're absolutely right, it needs to be continued to talk about. I met you earlier.
Yes.
Maybe
I'm so excited you're here because I've been talking about this for a long time, and this is the first time I've ever heard IDD talked about in this context. Thank you. But my children both don't qualify for IDD diagnosis, and I'm wondering, the conversation about there are delays in development and how it also parents have, my own stigma and hope that I don't want to label my child as disabled, and yet they fall into neuroatypical. I love that as a definition, but I'm really wondering about how you are addressing that, because I hear children's hospitals saying, if you don't have a diagnosis, we can't get paid. Thank you.
You present a problem, you present one of the holes in our system where you need something official before you're going to be able to receive the support that you need. We talk a lot about how our systems, our services are all reactive, right? And someone talked about it earlier, I think it was, maybe it was Todd, about being proactive, right? Going into the schools and providing the teachers the mental health supports that they are gonna need. So how can we be more proactive as a state? And instead of saying, all right, well, it's a Band-Aid, let's wait for them to fail, and instead, let's invest the money so that we can avoid, and I absolutely agree with someone said earlier, how do we measure the costs, right, or the savings from us doing this type of work? So it's please join us. We need your perspective and your conversation into it. We have a great IDD resources echo that I think you would be perfect for. So please join us.
Hi, thank you. I work for DDA, and one of my questions is, one of the barriers we see with some of our clients getting into mental health programs is evidence-based programs, saying that they don't meet the requirements. I've also seen this in SUD, where there's been requirements for memorization and no accommodations for the IDD diagnosis. Any of your thoughts would be welcome.
I mean, it goes back to equity, right? What is equity mean? It is providing someone with the enough support so that they can be successful. So our DDA clients, and I've been really excited about our partnership with DDA this past year. If you know Megan Hopkins, Megan's like our #1 fan. Hi, Megan. I'm glad she's here. So go talk to Megan about this stuff too. So, but you're absolutely right. Substance use disorder, there are no adaptations, right, for our autistic community. Right? So I think it's programs like this that Rachel has put together that allows us to say, hey, we got to think about this creatively and differently if we're going to be able to reach this broad group of people. So it's a great question. Thank you for asking it.
We'll take a question from online.
Okay, cool.
Are there any conversations about bringing this curriculum into graduate programs?
I would like to have that conversation with that person, so they are welcome to do it. But yes, we have just been, this past year we had a postdoc who is working on making connections with departments at the University of Washington to be able to provide support and training and an opportunity to learn in an interdisciplinary place, right? I'm an SLP, I didn't have anything. I didn't have any other connections. I had to do this all by myself to learn how to work with the psychologist, how to work with the doctors, the OTs, the PTs, and now, of course, all the mental health providers, right? It is really a steep learning curve when you don't have that in your practice, in your training, and that is absolutely integral. So OT, speech, ABA, those are 3 that we are going to be hoping to make partnerships with this year. So.
Thank you.
Yeah.
Thank you so much. We appreciate your incredible insights on something that again, when we talk about stitching this all together and removing those silos, so appreciative.